Talk about acid-base disorders about related to the renal physiology and biochemistry. So we know the general equation that CO2 plus water combines to form carbonic acid that gives us H positive and bicarb. So considering this reaction, if we increase the amount of CO2, which would eventually lead to the formation of more amount of H positive ions, and the more the H positive ions means the lesser the pH, and that would lead to acidity. Then the second scenario would be if we increase the amount of bicarb. If the bicarb is increased, it would combine with H positive ions. The reversible reaction would go to eventually depletion of H positive ions. That would lead to decrease in the H positive ions, increase in the pH, and lead to alkalinity in the body. Okay, so considering the acid-base disorders, there are four types of scenarios which are presented in different types of situations, and their relative compensatory mechanisms are also present. So first of all, there is the two types are the respiratory acidosis and respiratory alkalosis. In respiratory acidosis and alkalosis, the problem is mainly carbon dioxide, whether the increase or the decrease in the carbon dioxide. So in acidosis, since we have to produce acidosis, the carbon dioxide is going to increase, which would lead to increased H positive ions. That would lead to respiratory acidosis. And in respiratory alkalosis, carbon dioxide is going to decrease. Okay. Then the decreased level would eventually lead to decrease in the amount of H positive ions, and which would lead to metabolic alkalosis. Then we know that the normal first we should compare the normal values of pH and carbon dioxide and respective things. The pH normal value is 7.35 to 7.45. The normal value of carbon dioxide is 33 to 45. So if carbon dioxide is more than 45, it would lead to acidity, and if it is less than 33, it would lead to alkalosis. So it's better to remember these values. Sometimes you're not provided with these values. Now, considering the metabolic disorders, the metabolic acidosis, the normal value of bicarbonate in the body is 22 to 28. So, in metabolic acidosis, we have to increase the acid. So, bicarb is going to be less, so that H positive ions are not consumed by the bicarb, and the reaction goes back in the backward direction. So the bicarb levels would be less than 22, which would lead to metabolic acidosis. Then in metabolic alkalosis, the bicarb levels are going to increase, so that they deplete the H positive ion, the H positive pool in the blood, so that it would lead to alkalosis. Now we have seen these disorders. We'll see what are the compensatory mechanisms. We know that the kidneys and the lungs are friends. Let's suppose they are friends. So if there is a problem in the kidneys, the lungs are going to correct them, and if there is a problem in the lungs, the kidneys are going to correct them. For example, if there is a problem in respiratory acidosis, it would lead to compensatory mechanism, which is by the kidneys. So respiratory acidosis would be the compensatory mechanism of metabolic alkalosis, and metabolic acidosis would be the compensatory mechanism of respiratory acidosis. Similarly, if the problem is in the kidneys are not able to excrete, or they are over excretion of which bicarb is occurring, or it is less being produced, so the lungs will compensate. Metabolic acidosis will have the compensatory mechanism of respiratory alkalosis, and metabolic alkalosis will have the compensatory mechanism of respiratory acidosis. So lungs will compensate, and in respiratory mechanisms problems, the kidneys will compensate. Okay, now let's consider two scenarios which would clear your concept. So first of all, let's see that the pH is 7.28. The normal pH level is 7.34 to 45. We should consider that. Now we will see that the bicarb is 16 and carbon dioxide is 28. Now, first of all, what is the pH indicating? pH is indicating that there is acidosis. And what is the bicarb indicating? The bicarb is indicating that bicarb is less, ergo there is metabolic acidosis. metabolic acidosis. Carbon dioxide is also less, and it is indicating that there is respiratory alkalosis. Once we've written these, now we are facing an issue that there are both the blood ABG is showing that there are both the problems in the blood. So what is going to determine it is the pH that is going to tell you that what is the problem. The pH is 7.28, which is acidosis. So the problem is metabolic acidosis, and respiratory alkalosis is its compensatory mechanism. Secondarily, these are just hypothetical values just to clear the concept. pH, if the pH is 7.45, and let's consider this scenario that the bicarb level is 16. Again, the bicarb level is 16, so there is metabolic, their bicarb level is 16, so it is less, bicarb is less, so there is metabolic acidosis, and the carbon dioxide is also less, there is respiratory alkalosis. So since the pH is more, pH is indicating that there is alkalinity in the body, so ergo there will be respiratory alkalosis, and the bicarb level is less, so as to compensate the respiratory alkalosis. So these are the problems. Now let's consider one by one. Respiratory acidosis. In respiratory acidosis, there will be cerebral vasodilation and there will be cerebral edema. Okay. These are some of the majorly things which are asked. Then respiratory alkalosis. In respiratory alkalosis, there is tetany, and we should consider that the protein lose the H positive ions in the plasma. So why is there tetany? It is because the proteins have C double bond OH, so they lose the H positive ion. The H positive line once lost, there is a negative charge on C double bond O negative, that is the negative charge. So as to maintain the neutrality and the structure of the protein, the proteins use the calcium ions in the serum and the plasma, that is they consume it, and as a result the serum calcium level is decreased, so as there is tetany and respiratory alkalosis. Now we will be seeing about metabolic alkalosis. There are two types of metabolic alkalosis: chloride responsive and chloride receptive. These are not important at the level of MBBS, but further on they may be asked. So chloride responsive, in chloride responsive meaning that there is a depletion of chloride level, and chloride level is decreased, and there is volume depletion in the body. Why? There may be because of vomiting, it may be because of loop diuretics and thiazide diuretics, because of which the chloride is also lost. So to treat these patients of metabolic alkalosis which are chloride responsive, we are to give them normal saline, which is having the chlorine, so as to maintain the normal levels of water as well as the chloride levels are also compensated. Now chloride resistive metabolic alkalosis is in mineralocorticoid excess or aldosterone. So the chloride level is excess, and the volume of the body, the serum level and the water level osmolality is also increased. As a result, normal saline will not be very useful in this patient, and it will not improve the condition. Okay, now let's come to metabolic acidosis. In metabolic acidosis, this is important that there are two types of metabolic acidosis: normal anion gap metabolic acidosis, and there is the increased anion gap metabolic acidosis. So we should know what the anion gap is. Anion gap is the gap between anion gap is basically the unmeasured anions, those anions that are in the body but we do not usually measure them because if they're very little minute quantities. So for the calculation, sodium minus cations minus anions, so sodium minus chloride plus bicarb, these are the major cations and the anions. So the normal, we would see that there is 140 milliequivalent per liter of the level of sodiums and sodium ions, and chloride is 100 and bicarb is 26. Hypothetically, the value comes out to be 14, and the normal level is, this is to show that the normal level is 10 to 40, which is normal, 10 to 14. So to explain the normal anion gap and the increased anion gap, in increased anion gap, for instance, in metabolic acidosis, we know that we should consider that metabolic acidosis, considering what we have read in metabolic acidosis, the bicarb level is low. The bicarb level is low, but the body has to maintain its neutrality. So anions are to come, whether chloride will increase or whether another anion will compensate, will come in this equation or in the body, so as to keep the body neutral, keep the neutral, maintain the neutrality. So if another anion comes in place of bicarb, which is not measured because of its minute quantities in normal conditions, it will be caused an increased anion gap. And if the chloride level increases, then it will be normal anion gap, since the anion gap is increased, but it will be hyperchloremic metabolic acidosis. Now if another anion gap, we will see what happens if another anion gap, another anion, anionic acid is produced in the body. It will be, for instance, aspirin. In case of aspirin in the first 1 to 3 hours, aspirin, there is a problem that in the first 1 to 3 hours, that is, the aspirin is given in high quantities. In the first 1 to 3 hours, if it is given in abnormal amounts, it will cause hyperventilation, ergo leading to respiratory alkalosis. But in the next 3 hours, it will lead to the cells to destroy their mitochondria. Okay, if the mitochondria are destroyed, there will be no oxidative phosphorylation, ergo there will be anaerobic production of acids, which include lactic acids, which will lead to metabolic acidosis, let me see, which will lead to metabolic acidosis. Okay, then we will be seeing that what happens if another acid, which is ethylene glycol, is increased. Ethylene glycol and methyl alcohol are both used in the treatment of ethanol treatment, like if they are given in formipizole, etc., are given in IV ethanol. Okay? So if ethylene glycol is given, it will lead to increased glycolic acid and oxalic acid. Since these are also anionic acids, they will lead to metabolic acidosis. Then there will be methyl alcohol, which is example, methyl alcohol is the which is formic acid. So aspirin, which produce lactic acid, ethylene glycol, which breaks down to produce glycolic acid and oxalic acid, and methylene glycol via the alcohol dehydrogenase produces formic acid. All these organic acids lead to increased anion gap. Okay, now increased anion gap would mean in the calculation, how would we see, since there is increased anion gap? So sodium levels would be 140, but we would see that sodium level is 140 and chloride level is decreased. For instance, it is 100 instead of 110, it is 110. So that is why it is hypochloremic. But chlorine is not increasing to maintain the anion gap, and bicarb is decreased. But the picture which is not shown in this equation is that these anionic acids are being produced besides these. As a result, the anion gap is increased. Then in metabolic acidosis, there will be, in which there is normal anion gap, another acid is not being produced. As a result, the chlorine is being compensated, chlorine levels are increased, and bicarb is replaced by chlorine. So that is why there will be normal anion gap, metabolic acidosis, and it will be in the cases of diarrhea, cholestyramines, and sulfonyl uriases, and certain different drugs which are also having different descriptions. Thank you.